We are live and you can start.
Yeah, Upasana, please unmute yourself. Upasana, please unmute yourself.
Yes, sir.
Yeah. Okay. So please start your presentation.
Sir, is it visible?
Yeah, you are visible.
Yeah. Good evening, esteemed judges and my colleagues. I would be presenting a case report today. The title is Rare Case Report of Infant Ileal Atresia with Double Appendix. Coming to the introduction, terminal ileal atresia occurs in 1 in 3,000 live births of infant population. It is associated with bilious vomiting, abdominal distension, and non-passage of meconium since birth, and with dyselectrolytemia. Coming to the aims and objectives, after thorough clinical examination, the 3-day-old male infant was made to undergo several radiological investigations like ultrasonography of the whole abdomen and an infantogram.
Where are the slides?
Sir?
Please show your slides. Please share your screen.
So this is just a poster, sir. I did not make a...
Oh, it's okay. Then you showed us the poster.
Sir, sir, is it not visible, sir?
No, it is not yet shared actually.
Okay, sir.
You have to share, no?
If it is with Siddharth, he can show.
I can do that also.
Yeah.
This is actually poster, plum, basically poster as well as the free paper. Those poster can be presented as a free paper, and we have given them a time for 6 minutes and 2 minutes for discussion. So the faculty who are present here can take a call after her presentation. Thank you.
Sir, the poster is visible now?
Yes.
Yeah.
Okay, sir. Sir, should I repeat again?
Yes.
Please.
I would be, good afternoon, esteemed judges and my colleagues. I would be presenting a case report on, the title would be a rare case report of infant ileal atresia with double appendix. Coming to the introduction, terminal ileal atresia occurs in 1 in 3,000 live births of infant population, and it is associated with bilious vomiting, abdominal distension, and non-passage of meconium since birth, and with dyselectrolytemia. Coming to the methods, after thorough clinical evaluation, the 3-day-old male infant was made to undergo several radiological investigations like ultrasonography of the whole abdomen and an infantogram. The ultrasonography of the whole abdomen revealed dilated large bowel loops with collapsed small bowel associated with decreased peristalsis and normal vascularity suggestive of intestinal obstruction. X-ray plain picture abdomen revealed dilated bowel loops in the center with absence of gas shadow in the pelvis. The patient's mother was a case of gestational diabetes mellitus and was put on regular insulin in the antenatal checkup. General examination of the baby revealed severe dehydration, scoliosis, and right ectopic kidney. After thorough clinical, pathological, and radiological intervention, the infant was planned to be taken up for emergency OT, which revealed blind ending terminal ileum. The base of the cecum also revealed a bird beak or a double appendix, which is shown in the diagram which is below. The terminal ileum was resected and the proximal ileocecal anastomosis with double appendicectomy was done. Coming to the conclusion, it has been observed that one of the many causes of neonatal intestinal obstruction is attributed to small bowel atresia. These cases of small bowel atresia may have been associated with congenital anomalies, more so if there is an underlying antenatal morbidity in the mother. Hence, a holistic care in terms of genetic chromosomal typing along with surgery is necessary. Early surgical management of the case with resection anastomosis and early initiation of parenteral feeding has been associated with a successful outcome. At the last, I would like to acknowledge the invaluable contribution of Dr. Pinakpani sir, starting from conceptualization to the technique and guiding me. And I would also give a special mention to the head of my department Dr. Amitava Ghosh sir, whose support and guidance was indispensable in the completion of this study. Thank you, everyone.
Thank you, Upasana. You were the opener, and as you started this in a very nice way. And I thank all the viewers who have joined today, and especially our esteemed judges who are present here. And I request esteemed judges to start the proceeding. May I request Jaman sir, please unmute and start, and Noor also, you can start. We have got 2 minutes. Actually, basically, we got 2 minutes for discussion.
Upasana, hello.
Yes, sir.
Can you hear me? Yeah,
Yes,
it's
sir.
a nice presentation. What was the preoperative diagnosis?
The
Clinical diagnosis.
preoperative diagnosis, the patient had come with an abdominal distension with history of bilious vomiting and
That's
non-passage.
right. What was the diagnosis?
Sir,
Preoperative.
sir,
Provisional.
Sir, provisionally it was a case of bowel obstruction, intestinal obstruction, is it?
Okay. Did you do a rectal examination?
Rectal examination I did, sir. The rectum was collapsed, sir.
There is no
So the
mention
anal
here.
opening was there and the rectum was collapsed.
Okay. Dr. Tapno?
Yeah.
Please.
What type of ileal atresia was it? Type 1, 2, 3, 4. Which one was it?
Sir, it was actually a type 3A type of atresia.
Type 3A. Okay. So type 3A, that means there was a mesenteric defect also.
Yes, sir. Yes, sir.
Okay. Yeah. But I thought you said in your X-ray there was a large bowel gas shadow. Now, would you see large bowel gas shadow in type 3?
Sir, in type 3, a large bowel will not be there. Will not be
Yeah.
there.
So, because you mentioned that in the plain X-ray, a large bowel shadow was seen. So I'm not very convinced whether it was really large bowel shadow. That is number one. And the number two question was, what are the types of appendiceal duplication that happens, and what was the type of duplication in your case?
Sir, in the type of duplication, sir, it can be type A, type B, and type C, according to Walbridge classification, sir. Sir, in type A, sir, in my type, I found a type A kind of duplication of appendix, in which there's a partial duplication at the base of at a single cecum. There is partial duplication of the appendix at a single cecum, sir.
So actually, so do you call it double appendicectomy or single appendicectomy? When you do appendicectomy, basically you are dealing with the base of the appendix which is adherent or which is attached to the cecum. So it is actually a single appendicectomy that you do, not double appendicectomy.
Okay.
Right?
Okay, sir.
Yeah. So that was some of the things which I noted. Yeah. And regarding this patient also had scoliosis or something? Or what were the other problems with the patient, congenital problems?
Sir, this patient was actually a premature delivery. Sir, it was a male baby which was prematurely delivered. Sir, approximately around 7.5 months it was delivered, and it was it was low birth weight too. And in association with that, the baby had scoliosis, and the baby had when we did a sonography, in addition to small bowel obstruction, it revealed a right ectopic kidney as well, sir.
Yeah, I think the important thing here is whenever you have ileal atresia, and apart from ileal atresia, you have found one more bowel problem, that is in this case duplication of appendix. One should watch out for other probable associated anomalies in such patients. So it's good that you have done that, and I'm happy to note that you have done the genetic study. Okay. Only question is, in future, what is it that you are planning to do regarding the ectopic left kidney?
Sir, if it doesn't cause a problem and the urinary function is fine, sir, we need not do anything with the ectopic kidney.
Okay.
Where is the kidney, Upasana? Where is the kidney now?
Sir, we did not do anything with the kidney, sir. It was as it is, sir.
No. From imaging, where was it found? In the pelvis or where?
Sir, it was in the pelvis only.
Okay.
Okay, sir.
Okay. Thank you, Upasana, for your good presentation and equally sticking to your case. And in between, I welcome Professor Madhumita Mukhabeda Madam, as well as the moderator of this session. We have Nayanjyoti Das and Dr. I think Bhaskar Hajarika. They are also joined. So I think you can stop sharing, Upasana, and we can go to the next.
Thank you, sir.
Next, I think next is transverse testicular ectopia, Dr. Saugata Roy.
Yes, sir, I'm there.
Yeah, please start sharing. Dr. Swagata Roy is from AMCH.
Yes, sir. So is it visible?
Yeah, go to slideshow and yeah.
Good afternoon, respected judges, teachers, seniors, and my colleagues. I am Shogata Roy, second year PGT from the Department of General Surgery, and I am going to present a case report on transverse testicular ectopia, which is a rare anomaly. I was immensely helped by Dr. Manoj Gogoi sir, who is the assistant professor in the Department of Pediatric Surgery in Assam Medical College. Coming to the introduction, transverse testicular ectopia is a rare congenital anomaly and is also referred to as testicular pseudoduplication, unilateral double testis, and transverse aberrant testicle with maldescent. Associated abnormalities may include persistent Mullerian duct syndrome, true hermaphroditism, inguinal hernia, hypospadias, pseudohermaphroditism, and scrotal anomalies. Transverse testicular ectopia is an uncommon anatomical abnormality where both the gonads migrate towards the same hemiscrotum. Approximately around 100 cases have been reported in literature, and it was first described by von Lenhosek. We report a case of transverse testicular ectopia diagnosed preoperatively, and it was confirmed by surgical exploration followed by a repair. Our case was a 3-year-old male child who presented with the complaints of right inguinal hernia and absent testis on the left side. General examination and blood investigations were normal. On local genital examination, the left hemiscrotum was well developed, but it was empty. A well-developed right hemiscrotum with testis was seen. A single right inguinal swelling of 4 into 3 centimeter square size with testicular sensation and cuff impulse was present, which is shown in the picture. Ultrasound confirmed the presence of testis with one demonstrated in the right hemiscrotum and the other at the right superficial inguinal ring. Left hemiscrotum was empty and no Mullerian structures were seen on abdominal ultrasound. An open inguinal exploration was done, which showed right testis in the right hemiscrotum and a small left testis with an accompanying fluid hernia in the right inguinal canal. Both testes had a common mesorchium proximally and were separated by a distance of 4 cm, as seen in the picture. Herniotomy was performed and the lower right testis was placed in the left subdartos pouch by transeptal approach, and the left testis was placed in the right subdartos pouch. These are some of the intraoperative pictures which shows the inguinal exploration being carried out, testis being identified, and ultimately transeptal orchidopexy being done. Coming to the discussion part, embryologically, several theories are there regarding the origin of transverse testicular ectopia, including adhesion and fusion of developing Wolffian canals, aberrant gubernaculum, testicular adhesions, defective formation of internal inguinal ring, and traction on a testis by persistent Mullerian structures. Persistent Mullerian duct structures may result from failure of synthesis or release of Mullerian duct inhibitory factor, or the failure of end organs to respond to it, or the defect in the timing of the release of Mullerian inhibitory factor. It seems possible that the mechanical effect of persistent Mullerian duct structures prevents the testicular descent or leads to both the testicles descending towards the same hemiscrotum, which ultimately leads to transverse testicular ectopia. On the basis of presence of various associated anomalies, transverse testicular ectopia has been classified into 3 types. Type 1 is accompanied only by hernia and is the most common type, comprising about 40 to 50% of the total cases. Type 2 is accompanied by persistent or rudimentary Mullerian duct structures, comprising around 30% of the total number of cases. Type 3 is associated with disorders other than the persistent Mullerian Mullerian remnants, which include hypospadias, pseudohermaphroditism, and other scrotal abnormalities, and it comprises around 20% of the total number of cases. The mean age at presentation is 4 years, and the clinical presentation generally includes an inguinal hernia on one side and a contralateral or sometimes a bilateral cryptorchidism. Patients with transverse testicular ectopia are at increased risk of malignant transformation, with the overall incidence of malignant transformation of gonads being approximately 18%. There have been reports of associated embryonal carcinoma, seminoma, yolk sac tumor, and teratoma. Walsh et al. Concluded that testicular cancer was nearly 6 times more likely to develop in cryptorchid cases where operations were delayed until after the age of 10 to 11 years. Once the diagnosis of transverse testicular ectopia is made, orchidopexy is recommended for the preservation of fertility. Laparoscopy is useful for both diagnosis and treatment of transverse testicular ectopia and other associated anomalies. Management for testicular ectopia is either transeptal or extraperitoneal transposition orchidopexy. and there should be a search for Mullerian remnants or other anomalies, and there should be a long-term postoperative follow-up. In extraperitoneal technique, the testis is brought to the contralateral hemiscrotum, crossing the root of the penis. In transseptal technique, the testis should traverse the scrotal mediastinum to be fixed in it. So coming to the conclusion, transverse testicular ectopia is a rare anomaly whose pathogenesis still remains unclear. The diagnosis should be considered when unilateral hernia and concurrent cryptorchidism of the contralateral side are present. In suspected cases, ultrasonographic evaluation and laparoscopy may be helpful in diagnosing the condition before surgery. Transseptal orchidopexy is recommended to manage transverse testicular ectopia. Laparoscopy may be useful for both the diagnosis and treatment of transverse testicular ectopia and associated anomalies. These are the references which aided me in making my case report. Thank you.
Okay, you have exactly completed in 6 minutes, Saugata. So I request you to put up your poster.
Okay, sir.
Yeah, still open for discussion, sir. Examiner, please.
Sir, this is my poster of the same case report, sir.
No, you have to stop it first and then put it.
Yes, sir.
You have to stop the previous, sharing the previous one and then stop.
Close the file.
Yes, sir. Sir, is it visible?
Yes.
Yes, now it is coming. You can enlarge it if it is possible from your side.
No, it's not visible now.
Sir, one second. Sir, is it visible?
Yes. Yes, okay, fine.
Okay.
Sir, this is the poster of the same case report which I have prepared.
It's actually the poster seems full of text. No?
Yeah, very busy poster.
We have given a template for the poster actually, and when you make a poster, it should not be too much. The text should not be too much in the poster. Otherwise, it will not be visible. It's difficult to see in a one slide.
Sorry, sir.
It's okay, but the thing is, for the competition, all it will be going negative. It will not be. Your thing will go against.
Any questions from the examiner?
Saugata, yes. Hello.
Yes, sir.
Yeah.
Yes, sir.
And your presentation was good. And is there any place of any estimation of anti-Mullerian hormone in these cases?
Sir, preoperatively, we can go for anti-Mullerian hormone estimation. So if it is generally greater than 0.4 units, then probably there is inhibitory effect of anti-Mullerian hormone is present.
But in this case, did you do it?
No, sir. It was not possible. A patient party could not afford it, sir.
Okay. But it can be done, no?
Yes, sir, it can be done, sir.
Okay.
Okay.
I think there are examiners from outside also, and they can interact.
Sir, for this particular free paper, actually we are assigned from a local However, we could have only two among them, Nayan Jyoti and Bhaskar. Are you there? Nayan, please unmute if you're there.
If there is any pediatric surgeon, that will be nice.
Yes, we have Dr. Kinkar Mahanta, I suppose.
Yeah, Kinkar is there.
Yes.
Kinkar sir, Mahanta sir. Mahanta sir, please unmute.
This is a very rare case actually, isn't it, Saugata?
Yes, sir. Only 100 cases have been reported, sir. Till now, only 100 cases have been reported. The first case, sir, was...
Yes. Welcome, Kinkar Mahanta sir.
Yes. This is a very rare condition.
Yes.
This is a very rare condition I haven't yet come across in my own practice so far. It's so rare.
So would you like to ask anything? Would you like to ask anything regarding this case?
Shogoto,
Good evening.
this was a nice presentation. As a short case, Shogoto has presented nicely, and as you've rightly pointed out, the poster was very full of text. But then, as a case presentation, I think he has done well. No, nothing to ask, Shogata.
Thank you, sir.
Then can we move on to the next participant?
Yes. This next participant is
Grishma
Suresh. Yeah, a rare case of bilateral phylloid tumor in an adolescent female. Grishma Suresh is from Dr. Grishma Suresh is from Silchar Medical College. Swagata, please stop sharing.
Please stop sharing.
Okay. Thank you, sir.
Thank you.
Yes. Dr. Grishma, are you there? Yeah.
Yes, sir, I'm there.
Please share your screen.
Yes, sir. Sir, is it visible?
Wait, it's coming.
It's coming. Yeah, it has come.
Great.
Please enlarge it a little bit.
Enlarge it.
Kadria sir, welcome.
Thank you, sir.
Kadria sir.
Thank you, sir. Thank you.
Yeah. Please join.
Can it be enlarged some more?
Yeah, you can mute it
a little bit more.
Observe, sir. Yeah.
Can it be enlarged a little bit
I'm
more?
trying.
Okay, you do one thing. You stop sharing. I will share from my side. I will enlarge. Okay.
Okay, sir.
Fine.
Yes, it's okay.
আৰু অলপমান ডাঙৰ কৰি দে Okay.
Yes. You can start.
Great.
Yeah.
Sir, how will I scroll down? The control is it?
No, yeah, I will scroll down. You
Okay.
Start. I'll
Okay. Thank you, sir. So shall I start?
Yeah, sure.
Good evening, everyone present here. Here, I would be presenting a poster on a rare case of synchronous bilateral phylloid tumor in a 13-year-old female. Coming to the introduction, phylloid tumor is a rare fibroepithelial neoplasm of the breast, the median age of presentation of which is about in the 40th and 50th decade. They are usually well circumscribed. They have a lobulated and bossulated surface. They are locally aggressive in nature and they have a high recurrence rate. Coming to our case report, here we present a 13-year-old female with cerebral palsy with gradually progressive swelling of bilateral breast for a period of 8 months. There was no history of nipple discharge, rapid progression, or a positive family history of similar disease in the family. On examination, the general nutritional condition of the child was poor. She was oriented and alert, but had poor communicative skills. On local examination, on the bilateral aspects, there were lobulated lumps of around size of 12 into 11 centimeters and 13 into 12 centimeters respectively in the right and left breast. They involved all 4 quadrants. The overlying skin was stretched with prominent veins. The nipples on both the sides were retracted. The overlying skin was stretched with prominent veins. There were no palpable lymph nodes, but there was a tiny ulcer that we can see on the left. Actually, this was in the left upper inner quadrant of the breast, from which there was serous discharge. Now, here we have 3 images. The first one is the image that the child came with. The first image is that of the breast on presentation. The second image is following the mastectomy, and the third image is post-operatively, just before closure of the skin. Coming to the management part, triple assessment was done for the patient, beginning with the clinical examination that has been already discussed. On ultrasonography, the ultrasonography results suggested of a possibility of phylloid tumor with one axillary lymph node which was less than 0.5 centimeter in diameter. The FNAC was suggestive of borderline phylloid tumor. Routine preoperative workup was done for the patient, except for hemoglobin being a little on the lower side, which was 9 gram percentage. Rest of the pre-op investigations were normal. The patient was taken up for surgery. Bilateral subcutaneous mastectomy was done in 2 separate sittings, and with the infusion of with the transfusion of 2 units of blood after each surgery. The post-operative histopathological report confirmed the presence of benign phylloid tumor. Coming to the discussion part, phylloid tumor are seen in young females, and they are usually benign in nature, with most of the bilateral cases being seen in association with pregnancy or lactation. Triple assessment forms the basis for evaluation. The ideal mode of treatment is simple mastectomy or wide local excision with negative margins. There is a possibility of local recurrence and metastasis, which is about 6 to 10%, 25 to 32%, and more than 25% respectively in benign, borderline, and malignant cases. Chemoradiation is advised in malignant cases. Coming to the conclusion, phylloid tumor is a rare tumor of the breast with varied presentation. Triple assessment followed by surgery is the management of choice. Usually, simple mastectomy, even for the benign variety, is required because of the huge size on presentation. It is important to create awareness in females to have early consultation for any kind of breast lump. Thank you.
Yeah, excellent presentation, Grishma. And
Thank
this,
you,
topic is open for discussion. Sir, examiner, please take over. Jaman sir, Noor and Hirenda is also there. Orup, you can also join in.
Hello.
Yeah.
Yeah, I'm audible, right?
Yes, yes.
Yeah. Garishma, I just wanted to know, like, why did you choose this particular case for a case report? I just wanted to.
Sir, usually phylloid tumor are seen in older age groups, and this is a case of a 13-year-old female, which is rare. Plus, this is a bilateral synchronous presentation, which is again a rare case. And actually, we wanted to rule out possibility of any syndromic associations, which we tried to rule out. We did other investigations, which I have not mentioned in the in the poster. But the MRI report was suggestive of a sequelae. The child has cerebral palsy, which was as a sequelae to hypoxic ischemic episode during the during intrauterine period, sir. Other than that, there was no other problem. So this case was hello.
Yeah, go on.
Am I audible? Yes, sir. So this case being seen in a young female, and that too a bilateral presentation with such a huge size, it aroused a suspicion of malignancy in us. But then the post-operative HPE report was suggestive of a benign lesion, sir.
How old was the child? 13, right?
13, sir. Yes, sir.
Yeah. What is virginal hypertrophy of breast?
I'm sorry, sir.
Have you heard of a condition called virginal hypertrophy of breast?
Hypertrophy of breast, it is seen usually in prepubertal age group. It can be unilateral or bilateral, but then, hello, sir.
Yeah, you're audible. Go on. My question is,
Yeah, we can hear you. Please go on.
Sir, your question.
Okay, the question is this.
I did not hear that. How would you? Yes, sir.
Can you clinically distinguish between, in this case, the phylloid tumor versus, let's say, a vaginal hypertrophy of both breasts, which is more common actually? Clinically, how would you describe it?
Usually, sir, this one. The the vaginal hypertrophy of breast, it would be the breast would be soft in consistency, and this has a gross. The surface itself is lobulated. It has a bossulated surface with enlarged prominent veins with the stretching of skins. These features are usually not seen in vaginal hypertrophy, sir.
Exactly. And I think you also mentioned about nipple retraction being there. Okay. So these features,
Yes,
the
sir.
skin
Yes, sir.
changes which you see, including the ulceration, which is there in this case. There's ulceration, there's retraction, and the skin changes. You said the surface is bossulated, and also the consistency is
Yes.
not exactly soft. And the most important, there are dilated veins which are there. That's called telangiectasis,
Yes.
which you see in classically in phylloids. So I think clinically itself, of course, considering the age, you probably would not think of phylloids, but everything else, except if you probably do not know the age, I think your first diagnosis would be, I think, phylloids. Yeah.
Dr. Grishma, can you hear me? Hello?
Yes, sir. We can.
Yes,
we
sir.
can hear you, sir.
Fine. So what was done actually? Subcutaneous mastectomy with the preservation of nipple and areola, is it?
Yes, sir.
Did you preserve the nipple and areola or not?
Yes, sir. It is preserved, sir. It is there in the image also, sir. Nipple areola complex was preserved, sir.
Okay. So why there should be a nipple retraction in the case of phylloids?
Sir, in this case, it is probably due to the ductal. Sir, there is fibrosis. Associated fibrosis is also there. It is probably due to the fibrosis and the ductal component. There is fibrosis and which pulled inside the nipple areola complex. Sir, I'm not very sure, sir.
Why there is retraction in carcinoma of the breast? Nipple retraction?
So that is probably due to infiltration, sir. Infiltration causing.
Infiltration of what?
Of what?
So infiltration of the duct, sir.
Which
No,
duct?
no.
What is
The
duct?
terminal lobule, sir.
No,
Sorry,
no.
sir.
About,
No. Absolutely no.
Is there any other structure which can be infiltrated?
Is there anything that goes from the pectoralis major fascia up to the dermis of the skin? What are the
Sir,
structures?
ligaments of Cooper, sir.
Yes.
Cooper's.
Oh, here probably, I mean, just to speculate, the retraction is actually a pseudo retraction. Probably there is masses.
That's right. There's a
grown around
size
it,
is
which is
so
covering.
big. Yes,
It's the reverse.
size is quite big, so it is more stressed than retraction.
Yep.
What do you say? Yes. For triple assessment, you have done FNAC. Is it FNAC better, or you could have done something else?
Yes, sir. Initially, sir, we could have gone for a biopsy, but then we went for FNAC, which was feasible initially, and we could have done mammography, sir. Ultrasonography. I'm sorry, sir. You're asking only about the cytology or all three, three components of triple. So we could have gone for a core needle biopsy, sir.
It would have been better. It would have given you more information than the fine needle aspiration. Core biopsy is
I just
better,
want to,
right?
sir, I just want to play the devil's advocate. When you have an ultrasound which was done, which has told you that most likely it's a case of phylloids, would you in that situation still like to do a core needle biopsy? Just point of discussion.
Ultrasound is not a very good investigation for the breast.
I know it's not, but
yes, they have not done even the mammography also.
No, I think
should have been done.
The point here is cystosarcoma. I mean, phylloids tumor at this age is rather uncommon.
Very uncommon.
Malignancy is again very rare. And FNAC at least it will do is it will rule out the possibility of infiltrating duct carcinoma, which anyway is a rare thing to be thought of. And anyway, if you're planning for
bilateral also.
Bilateral. And when you're planning a subcutaneous, mastectomy, the advantage is you get the whole tissue and, hopefully enough of the breast is left behind so that later the functions can be taken care.
No, they have done a mastectomy, no? They have taken out all the breast.
They have done a mastectomy in this case, sir.
No, are you sure it is when you plan subcutaneous? Because here, wide local excision is not what you should be thinking of, and what probably you should have done, in my opinion, is given the age and all that. Of course, one may argue that it's a Down's syndrome child, but that's not the reason why you should actually go on to remove the breast. Probably it would have been a better idea if you could save the. But the question is whether it is possible. I think for that information, probably if you have done a core needle biopsy and clearly known that yes, it's a benign condition, maybe this is something that could have been thought of.
Exactly.
Yeah.
Exactly. Okay, then we thank you. And any more questions on this?
No, I think we're done, sir.
Fine.
Thanks.
Thank you, Girish.
Okay.
Rocket, back to you.
Yeah, so the next participant is Dr. Sneha Daniel. She is also a postgraduate from Silchar Medical College. Her topic would be a rare case of hepatic flexure perforation following blunt trauma abdomen. So Sneha.
Good evening, sir.
Yeah.
Good evening.
Good evening.
You can share the slide.
May I share? Okay, sir.
In between, I welcome Professor Deepak Sharma sir, Diganta Borgohain. I think our professor, there are so many. Albert sir is there. Ujjal, Dhirenda. And I think our president is also there. I think he has joined it from other
yes.
equipment. That's why we could not follow his name. Anyway, you start.
Yeah.
So may I start?
Yeah.
Sure.
Good evening, respected judges and moderators and my dear colleagues. First of all, I would like to articulate my gratitude to the organizing committee of Asacon for giving me this opportunity to present this case. And to begin with, I will be presenting a case of a hepatic flexure perforation following a blunt trauma to the abdomen. Introduction. High-velocity accidents compounded with seatbelt injuries have led to an exponential increase in blunt trauma to the abdomen. While the incidence of hollow viscous injury following a blunt trauma abdomen is documented at around 2.7%, colonic injuries are a rare complication. Here, we will be presenting a case of a 30-year-old male patient who presented with an isolated hepatic flexure perforation following a road traffic accident. The case presentation. My patient was a 30-year-old male who presented to the emergency at Silchar Medical College and Hospital with pain in the abdomen 3 hours after a blunt trauma to his abdomen due to a road traffic accident. There was no relevant past medical, surgical, family, or psychosocial history. Like we can see, this is the presentation. On presentation, the abdomen was, the patient's vitals were stable. There were no visible external injury marks on the abdomen. The abdomen, there was just slight mild tenderness and localized guarding in the right upper abdomen. The peristaltic sounds were heard normally over the abdomen. And we proceeded with an emergency extended fast, which showed minimal free fluid in the peritoneal cavity. As we can see this here, we could see minimal free fluid in the peritoneal cavity. And we also proceeded to go on with a chest x-ray PA view. The fast also did not give any definitive indication of any hollow viscous perforation or solid organ injury, and there was no evidence of hemoperitoneum. On doing an abdominal radiograph, we did an abdominal radiograph and a chest x-ray PA view with the bilateral dome of diaphragm. So like we can see over here, the patient, there was no visible abnormality and there was no air under the diaphragm. Sorry. Sorry about that. So we admitted the patient for monitoring and we kept the patient nilperoral with an NG tube in situ. On admission, the patient's vitals were, like I mentioned, stable. His heart rate was 86 beats per minute, regular. His blood pressure was 90 by 60 millimeters of mercury and his hemoglobin was 15.4 grams per deciliter. At about 6 hours of observation, the patient's general condition started deteriorating, and he started developing severe abdominal pain, which was not relieved by analgesics. He developed tachycardia with a pulse rate of 102 beats per minute, hypotension with the BP falling to 80 by 50 millimeters of mercury, and his oxygen saturation also dropped to 92% on room air. His abdomen appeared distended, and guarding was apparent with the obliteration of liver dullness. The peristaltic sounds became sluggish, and the digital rectal examination showed an empty rectum with fingers stained with stool. So we immediately started the resuscitation of the patient with IV fluids and PRBC transfusion, and we shifted the patient to OT. And on exploring, we continued with an exploratory laparotomy, which was performed using a midline abdominal incision. On opening the abdomen, moderate debriginous peritoneal fluid was noted, which was suctioned out. The solid organs were inspected for any kinds of injury. The bowel was traced from the duodenojejunal junction distally, and the large bowel was explored. On exploration, it revealed a perforation at the antimesenteric border of the hepatic flexure. Once we confirmed this, there was a leakage of stool, like we can see in this picture. I'm sorry. Like we can see in this picture over here, there is this is the point where we found the stool to be leaking. So once we confirmed that there was a stool leak from there, we continued to repair the perforation, hepatic flexure perforation, after partially mobilizing the right colon, because that is a very difficult area to access. So we partially mobilized the right colon by making an incision over the white line of Told, and we did a primary repair with the
Your voice is gone.
I think she had a network issue, maybe. So Siddharth.
She was fine till now.
Yeah. Siddharth.
Sneha, are you there? Sneha? We cannot hear you.
Yeah. You want me to play it out?
Yeah,
Hello?
that's why now. First of all, whether
She is coming back. She is coming back.
Okay, fine. Okay, fine.
Okay. In between, I've seen Prabhas Da also. Prabhas Burman, Dr. Prabhas Burman, welcome.
Hi everyone. Good evening.
Hello, sir. Hello, sir.
Hello.
And we can see our president, Bora sir. Khataniyar, you are from Khataniyar. Bora sir, welcome. Sneha, are you there? I think she's having a network issue.
Should I?
No, whether she's not there, so
she's almost done, I suppose. Just a little bit.
Few slides are there. What you can do is, I think we can go with the next paper.
Presenting, that can be done.
Yes, sir. We can go with the next paper, and if the time is there, she can again come back, because we have got.
Sir, I'm back. Hello.
Yeah.
Come back.
I'm so sorry that electricity went off in this place. I'm so sorry. Sir, should I continue where I left?
Yes.
Sure. Please.
I'm extremely sorry for the disruption. I'll just.
It's okay.
This is the handicap for them. Online.
So you were there in this slide 6, yeah, fine.
So I will continue from here.
Yes.
So as I was saying that we shifted the patient to the OT with continued resuscitation with IV fluids and transfusion of blood products. And we did an exploratory laparotomy, which we performed using a midline abdominal incision. We found a moderate debriginous peritoneal fluid, and we suctioned it out. We inspected all the solid organs for injury. And we traced the bowel from the duodenojejunal junction distally for any perforations. While exploring the large bowel, we found a perforation at the antimesenteric border of the hepatic flexure. Once we confirmed the stool leak, Like we can see over here, this is the leak which we found. Once we confirm that, because hepatic flexure is a difficult area to access, we partially mobilized the right colon by making an incision over the white line of Tolt, and we did a primary repair with an omentoplasty, and we did a loop ileostomy for diversion. The patient was then shifted to the ICU for recovery, but the patient succumbed to respiratory complications.
Oh, that's very
Discussion. The enteral structures which are most vulnerable to injury following a blunt trauma to the abdomen are usually the small bowel and duodenum. The mechanisms involved in the injury, both colonic as well as the small bowel, are similar. So what happens is either a loop of bowel gets caught between the blunt structure striking the abdomen and a rigid structure, commonly the vertebra, or there might be a devascularization of the bowel following a mesenteric tear due to rapid acceleration and deceleration. Another mechanism which is involved in sigmoid colon perforations is if a laceration caused by raised intraluminal pressure, that can also cause an injury to the sigmoid colon usually. While FAST has become readily available at most centers, it has to be noted that it is operator dependent and it has a low sensitivity to detecting free fluid in gastrointestinal tract injuries following blunt trauma abdomen. The role of CT in emergency situations is debatable because what happens is a lot of time is lost in patient preparation, and administration of contrast involves a few more complications which we have to think of, and it is not always feasible, it is not always affordable by the patient. So as even in our case, we were not able to go for a CT of the abdomen. But if we were to go for a CT, and a CT finding that would indicate an enteral injury include the presence of free intraperitoneal fluid without the evidence of solid organ injury, intra-abdominal free air, mesenteric thickening, leakage of contrast, and intramural air. Over the decades, much has been said about the repair of colonic injuries, and now a primary repair is being preferred over diversion with a stoma. But a colostomy is favored in patients who present with preoperative shock, massive hemorrhage, involvement of more than 2 intra-abdominal organs, where in cases where there is severe fecal contamination, if there is a delay of over 8 hours to operation, and if there is massive loss of soft tissue. To conclude, diagnosing like when we are presented with a situation of blunt trauma abdomen, while solid organ injuries are more common, we need to have a large index of suspicion to diagnose any gastrointestinal tract injuries. Specifically, colonic injuries, we need to have a large index of clinical suspicion, because otherwise, while we have other modalities to diagnose, because of the low sensitivity of those modalities, if there is any delay in diagnosing, we might end up with a bad outcome or a poor outcome. These are the references that I have used in my case. Thank you. So my poster.
Do you have a poster?
Yes, sir.
Yeah,
I have
please
my
upload
poster.
ready.
I will just share my poster, sir. Just
welcome, Dasar, Nitin Dasar. Sarok Sini Poan Aslu, Protome, because you have joined with Apo. But after looking at your image, we can make out. Welcome,
so this
sir.
is my poster.
Yeah.
Okay.
Unmute ko paribo, sir. Tarpisar video.
So this is my poster.
Okay.
Dr. Daniel.
Yes, sir.
Hello. Yeah.
Yes.
While on your examination part, when you presented, you talked about X-rays and the FAST and everything. Then came to pulse, BP. Is that how you examine a patient? You send him to the
No, sir. No,
department?
sir. We went with the general physical examination first, sir.
That you have not mentioned anything. I'm sorry, but your investigations came first.
Sir, on immediate.
Not here in your presentation. While in your paper, I have not seen whether we'd like to know if there was any rigidity in the abdomen, and the withdrawal liver dullness was obliterated. And
No, sir.
Unless the patient is in shock, I think you can do a little bit of abdominal examination properly, and also general examination, like your whether stable or not. So these things are important.
So actually, I actually categorized my examination into 3 parts. First was the immediate examination at present.
That's okay.
After
That's fine.
examining the patient, I went with the emergency fast, and then I again examined the patient on admission, because there was some time delay between the examination of my patient. After presentation to admission, there was some time delay of around an hour or so. So in that time, sir, I got these investigations done, and then again I examined. Sir, we had admitted the patient for serial abdominal examination.
No, that's fine. Last part is okay. After 6 hours, you've done a repeat examination. That's fine. On immediate examination, that it didn't mention about the vitals.
Oh, sorry,
anyway,
sir.
it's
So
all right.
vitals was
Okay.
I just wrote it down. Sorry, sir. I will make sure
And
that
my
it is
other
changed.
question is in abdominal trauma, which structures get mostly damaged?
So usually, if there is a blunt trauma to the abdomen, it is usually solid organs which are more involved than hollow viscous organs. And in the solid organs, there is more risk to spleen and liver, sir. And then there is the root of the mesentery. There is always chances of damage to the, because the root of the mesentery is a fixed structure, so there is always chances of damage there, sir.
As far as the intestines are concerned, which are the areas mostly damaged?
So the fixed parts, so the most common part to be injured would be your duodenojejunal junction. That is why we began tracing the bowel from the duodenojejunal junction only, sir, downwards. So from
it is not the fixed part. Fixed part and the beginning of the mobile part. Junction of the fixed part and the mobile part.
Okay, sir.
Fixed part do not get damaged as such. Yeah. So hepatic flexor, is it a fixed part or it is a mobile area?
So it is a fixed part, sir.
How fixed?
It's retroperitoneal.
Retroperitoneal.
Sorry.
Hello.
Any comments? Yes.
Hello.
Any other comments? Hello. Other examiners, please ask questions.
Hello.
Dipogda.
Dr. Topno.
Yeah. I'm there, sir.
Yeah, please.
You have apparently given one PRBC transfusion before you took the patient up. What was the reason for transfusing? Because you have said that only after 6 hours the patient condition deteriorated. So was there any obvious bleeding? Because why have you given the PRBC?
No, sir. There was no obvious indication that there might be a hemoperitoneum or bleeding. But sir, because we were resuscitating the patient, and while resuscitating the patient, we had given him a lot of IV fluids already, and we gave a PRBC because in case there is any solid organ injury, which we might encounter, like I said, injury to we had not suspected it to be a perforation initially. So in case there was any associated solid organ injury, for that case, we had administered a PRBC transfusion, sir.
Because transfusion of blood is to be taken very seriously. We do not transfuse blood just because we think that hemoglobin may be low or they may be bleeding, because we have no document. You have done a fast before that, and of course, your patient on observation at 6th hour, you have found that the patient's general condition has deteriorated. So, this is my personal view. I think we should not run into giving transfusions unless there's a definite indication. And in this case, there was no bleeding from external source. So far, whatever the imaging was done did not show any blood. However, it doesn't matter. Yeah, that is one point that you need to keep in mind. Yeah.
Hello.
Other thing about blunt injuries is, apart from the sites which you have mentioned and we have discussed, these are the common areas, there is a very classical type of injury. You get the cycle handle injury, okay, which is actually a form of blunt trauma but usually it is the bowel loops which perforate, and usually it is the jejunal loops. So while we also need to understand that the mechanism, the actual in RTA is a very broad term, but within RTA we need to understand what is the mechanism of injury. Like you have mentioned about deceleration injuries, that is one. Then you have very typical types of injuries happen. And the RTA, was it a bike or a car? This was a car.
So he was riding on a bike actually.
Yes, in a bike you can very well have those handle injuries, and there you don't have much of other findings, but patient will have actually a perforation. And what was the point where the perforation had happened? It was on the antimesenteric border.
Yes, sir.
See, because we need to also understand that the hepatic flexure has both a retroperitoneal part as well as a peritoneal part.
Peritoneal part, yes, sir.
So if you have the involvement happening in the retroperitoneal part, which is quite close to the antimesenteric border in this case, many a times the patient will be largely asymptomatic to start with. And that is exactly what happens classically in the case of duodenal injuries in the retroperitoneum. Okay, so I think this is very much a case of that. And that's the reason why initially patient has not presented with symptoms.
No, Dr. Tapno, they found the injury in the antimesenteric border.
No, but when you look at the antimesentery of this, there could be probably a
free area, no? That is the presenting area.
Because hepatic flexure is a fixed part.
Yes, sir.
Hello.
Yes, Deepak Sharma, sir. You wanted to say something, sir?
Yeah. So the initial presentation shows that your blood pressure is 80/50, no? As well as
so 90 by, yes, sir. No, sir, it was not 80/50 on initial presentation, sir. The initial presentation, it was 90/60, sir.
90/60, as well as
the vitals were stable.
No. SpO2 was your 92.
Yes, sir. That was, sir, after 6 hours of observation, sir.
So
after
if
observation,
SpO is 92, at the same time there is no bleeding, there is your 90/60. So there is no indication of giving blood, as because there is no evidence. Second point is if there is SpO2 is 92, have you given oxygen? Because this person died later on because of respiratory complications.
So we had given the patient oxygen. The patient was on oxygen. Even while transporting the patient, he was on oxygen.
So what was effect of oxygen after giving? That's what is what was the SpO2
giving oxygen, the SpO2. So
it improves means how much?
Improved a bit, sir.
Your patient died of
like once we noticed that the patient, so 94.
94. The person died of respiratory complications. 94. No. So it is.
Yes,
I think there is some other reason other than your surgery, which has caused that. And doing surgery is not enough. I think so. You will have to take care of other areas so that you can get a good result. So what are lessons that you can learn from this presentation, because your patient died, no?
Yes, sir.
So what are lessons? What are lessons that you can learn from this?
So the first thing is I have learned is that I need to have I have to be open to the diagnosis of holoviscous perforation even when the patient is presenting with a normal thing, and a regular clinical examination has to be done. In our case, sir, the patient, we were not able to extubate the patient only, but the chest X-ray was normal. There was no injury to the chest.
You could not extubate.
That is why I put. We were not able to extubate the patient.
No, you said respiratory complication. What type of respiratory complication? Respiratory complication is not enough. What actually happened?
So the patient was shifted to the ICU, and the patient was on ventilator only for some time, sir.
Okay, you don't know exactly what is the cause, no?
No, sir.
Okay, Dr. Sneha, for your excellent presentation. I think we should. I think we have to move forward because after this session we have got a GBM. So
we are having a last participant.
Yeah, there is one more paper. Actually, this paper was for the competition. However, the presenter want to present as a free paper. So we have shifted this paper into free paper segment. Role of intraoperative leak testing in bowel anastomosis by Dr. Said Yasin Shadas Imani. He's from AMCH. I request Yasin, Dr. Yasin, to share the screen and present as a free paper.
Hello, sir. I'm about to share my screen. Is it visible, sir?
Yeah.
Sir, is my screen visible?
Yes, it is.
Okay. Good evening to all respected panel members, senior faculty members, or to all my colleagues present here. So in this free paper session, I'm about to present the role of intraoperative leak testing in bowel anastomosis. This is actually part of my thesis, which was done last year under the guidance of Dr. R.C. Brahmasar. So to begin with, we know that anastomotic leak is still one of the most expensive complications of GI surgery. And anastomotic leak testing is a common tool to judge the integrity of anastomosis before we decide to close the abdomen. However, this is still not routinely used in many setups, even as of now. And this method is described in the literature for both stapler and hand-sewn anastomotic methods. For our study, we took all consecutive patients in our institute who underwent bowel anastomosis. However, we excluded all comorbid patients, such that we cut off hemoglobin at 8 and albumin at 3. So we excluded the patients below them, and we excluded patients with severe comorbidity like uncontrolled diabetes and chronic diseases like tuberculosis. And so the eligible patients were enrolled for a prospective analysis. Since leak testing is not done routinely in our institution, so for our study, the leak testing was done as per the surgeon's description. In the colorectal anastomosis, we use the traditional method. And for small bowel anastomosis, Gladman's method of 2007 was used, which I will describe later. We did overall analysis and also analyzed as per subgroups of small bowel and large bowel subgroups. So this is the Gladman's method for testing anastomotic integrity of small bowel anastomosis, where we basically Z-track a needle inside the lumen of the bowel, and then we inject air and again put the anastomosis under some water and try to see if there is any air leak. So in our study, the primary outcome was anastomotic leak with secondary outcomes of surgical site infection and mortality, which were directly related to the anastomotic leak. In case we found any leak after doing the intraoperative testing, we differentiated those leaks into first, whether the leak is a clearly defined defect, which is well localized, and in an otherwise healthy anastomosis. So if it was like that, we used to suture repair and did the repeat anastomotic leak test. However, in some cases, the defect was posterior in location. It was not very feasible to clearly visualize the defect. And in those cases, we used to redo the anastomosis or opt for a diversion enterostomy. So this is the main table from the results of our study. As we can see, we enrolled a total of 102 patients, in which 55 anastomotic leak testing was done. And in 47, it was not done. We tried to find the difference, whether there was any significant difference in leak rates among these two groups. So as we can see in the overall column, there is a significant difference in the leak rates of both the groups. And also there is a significant difference in the large bowel group. In the small bowel group, although there is a difference, the p-value is not low enough to call it a significant difference. This is a bar diagram representation of my results. As we can see, in all the subgroups where there was leak, we see that the anastomotic leak testing was in less number of patients. And the second bar from the left, we can see that when there was no leak, then the anastomotic leak testing was done in more number of cases. This is another representation which shows that in cases where anastomotic leak testing was done, actually the leak rates were much less. So how do our results compare with those present in the literature? In 2016, Skiff et al. Did a meta-analysis of over 2,000 cases where they showed a lower leak rate in the population with an air leak test as done in our study with a significant difference. Also in 2016, there was another study where they also showed a significant difference in the clinically detectable anastomotic leak rates. Way back in 1990 also, intraoperative leak testing was done and using the repair of colorectal anastomosis. And they also found that there was significant difference both clinically and radiologically. So this is another study by Bocola in 2010, which also echoes the same results as in our study, where they identified leak rates of 7.7 with positive anastomotic leak testing and 3.8 with negative anastomotic leak testing. So in conclusion, the intraoperative anastomotic leak testing, as seen in the literature as well as in our study, it is an effective tool to judge the integrity of anastomosis. And it should be routinely used in all cases, in all kinds of setup, and it should not be left to the surgeon's discretion. We have seen from our study that Gladman's method for small bowel anastomotic integrity testing is effective, and this should also be incorporated in the routine protocol. However, further studies are needed to generate a higher level of evidence and also to explore newer methods of intraoperatively testing the integrity of anastomosis. Thank you.
Thank you, Yasin. That was a wonderful paper. Now over to the judges and CG members for any questions.
Sir, are you trying to share your screen with your mobile?
Yes, sir.
That was good. We didn't find any difference between mobile and this laptop. Is it, sir?
What was that?
Yeah. I'm using mobile. Yeah.
Yes,
mobile
sir,
is
you
good.
can ask,
yeah.
Sir, you can ask.
So, like about his about his subject. Yeah, he has covered well. Yeah, like he has well covered this leakage thing. But one thing is that one has to be very careful about that, like because leakage infection, these are the surgeon's nightmare actually.
Sir.
Like we have to do proper investigations, as doctor has mentioned. We have to follow it up properly, and then you have covered nicely. You have to follow up according to. It's a nice paper you have presented. It's very useful. Yeah, good.
Thank you, sir.
Deepak.
Hello.
Yeah.
Good evening, sir.
Good evening. So this is a simple procedure, but at the same time, I think it is a very useful procedure because, as you know, we have to work in under many constraints. So it is, I think, a very useful method to find out the leakage method. But do you think this is an absolute method?
No, sir. This is not an absolute method. However, since we are faced with a lot of dilemma before closing the abdomen, and most of the times in emergency, whether we should go for a diversion enterostomy or not. So I think this test can guide us during that time.
So I think more important in leak is the other factors. If you're looking, if you're, I mean, the anastomosis is done in a proper position. That means if it is loose enough. Loose enough means, I mean, the loops are loose enough, so that there is no strain on the anastomosis. If there is no distal obstruction and other factors which affect, that are more important, because it has been seen if there is minor leak also. If the other factors are okay, usually it heals. So that's why it can be a part of your game that you can seek the leak. But I think at the same time it is important to see other factors also. I think specifically we have seen that we sometimes do anastomosis in a very you can say inside out, outside in, sometimes in a regular manner, sometimes in a haphazard way, but still it has been seen. Once the other factors are okay, even if you do a, say, initially it seems to be a very, bad anastomosis, but still the heals, and sometimes a good anastomosis we have seen. And even if there is no leak at the time, it may leak later on. So I think leak is a problem which is not a single factor; it's a multifactorial. And we
Yeah,
have
the surgeon skill also comes into play. Sir, Jaman sir.
Dr. Yasin, yes. Can you hear me?
Yes,
Yes,
sir.
I can hear.
Yes, that's right. A very different type of paper, unique paper, I would say. I never thought that these things are done. And I have not done any leak testing so far in my career. However, it's a good thing. What I'd like to ask you is that, did you try to correlate the leak test to the type of suture, whether intermittent, continuous, used for the anastomosis?
No, sir. Actually, in part of my thesis, I analyzed whether there was any difference in the type, difference in leak for the different type of suturing methods used different, and I did not find any significant difference between them. But I have not correlated that data with the leak testing, sir. But sir, definitely this is an interesting lead, and I would like to follow up with the data that I have.
Because now most of the surgeons, they use intermittent sutures,
yes,
and they think that surgeons think that they for the vascularity of the part, and not a very watertight sutures or continuous type, multi-layered type. So single layered interrupted is the most preferred suturing method. So it didn't try to correlate. However, I think it would be a good idea to correlate. Then we can have a message that this suture material, this type of suturing is probably better for as far as prevention of leakage is concerned. So from your result, what was the message from your research?
So my message is that we should incorporate leak testing as a routine tool in our anastomosis procedures, and also, sir, do more studies and try to correlate more variables, like you said, with the leak testing.
Good, and congratulations, and very unique type of testing is good for the surgeons, no doubt. Surgeons can at least sleep. Thank you.
Thank you so much, sir.
Thank you.
Sir, if there is no more question, because we have to wind up, because by 5:30 we are having another.
I just wanted to make one observation in this.
Yeah.
See, the problem here is when you do the leak test using air, the problem is the density of air is much thinner compared to the density of the enteral contents that are ultimately going to come out and determine that yes, it is a leak. Okay. So what is happening is you are once even air is coming out, you are actually resuturing that area. So the danger here is that you may end up with a very tight suturing in that area, because sooner or later the local edema will kick in, which is part and parcel of the bodily response. And actually the sutures will become tighter. So the chances of strangulation actually are quite real. Okay. And ultimately what is important for the integrity of any anastomosis is, number one, the vascularity. So my only misgiving is that whether you actually end up making the anastomosis very tight, because there have been some studies, I'm not very sure about the study, where it was shown that on table there is leak, air testing has been done and there was leak, but all these things have actually gone on to heal okay. That has not been an issue at all. Of course, if you have major air leak, that's another matter. But few bubbles coming out, I don't think is a matter of worry. And in case you're using interrupted sutures, it is quite likely that you're going to have it. And it also depends on the thickness of, like in the colon, where the colon is much thinner, and jejunum, which is much thicker. Obviously, in jejunum, you're not going to get a leak. And you can have an airtight anastomosis in an avascular area also, and that is anyway going to leak irrespective of whatever you. So these are some of the areas where we need to be careful before we, say it is good or bad, because these things have been tried out in the past, but somehow they have not stood the test of time. Yeah. That's what.
Okay.
Thank you, sir. Dr. Sir is right, I think, because in some study it has been shown that particularly in colonic anastomosis, there is some amount of leak in almost all, but it heals. There are a few evidences in literature. So it is not always necessary to be very, very tight. So
yeah.
I agree with that. Most
important is the there are always limitation for the studies, and because our postgraduates have got 1 year the time frame for that, and we can always extend that. We were telling Yashin also that some of the things were been mentioned by Jaman sir and Noor and all the respected teachers here, that there are, we can always extend the studies. Whatever it can go on for more duration, where we can incorporate all the studies, all these and parameters into the studies. So I think it's a good suggestion, and obviously Yashin will take note of this. Thank you, everyone. And because we are going to be short of time, once again, welcome you all and thank you all for being here. Today is the first day, and we are very much pleased to by your overwhelming response. Actually, we were always skeptical that there might be some problem and the audience will be very less. So we are very much thankful to you all for being here. And I request our President Bora sir, please give your last comment before we wind up, because we have got a GBM, and this platform is not for GBM. I request everyone to sign off from here, and there will be a separate link from, if you have registered from your email as well as the mobile number, you can go in straight. So there will be another link. Bora sir, please wind up with a note of.
I am sharing the link for the GBM to attend the GBM once more.
In that,
please request anybody on the platform who has not registered, please register for the GBM.
Bora sir, unmute and give a concluding remarks. Yes, so Bora sir, apna ko mute रह जाए.
Yes, okay. Thank you, Dr. Bromo, for this very nice webinar. And for the presentation of papers. The presenter, they have very nicely presented their papers, and I think, as Dr. Daman sir already told it, this leak test I have never done in my life during the anastomosis, and I think there maybe some leak, there's a minor leak, because the two type anastomosis is not good, I think, for healing of the anastomosis. Okay, and I thank all the presenters for present their papers in this session. Thank you very much.
And thank you all the moderators also. We have got a moderator and the teachers for joining. And I request you all to join for the GBM. I think we can close this session. You can leave the session.
Okay. Thank you. Bye-bye.
Thank you.
Yeah. See you tomorrow. Actually, I request all today is a trial run, actually, dry run, what you call. Tomorrow we'll be having a competition paper.
Today it was fantastic. We all enjoyed. Your presentation came very nicely and clearly. I congratulate the team of Gunabi and Rocket and Siddharth.
Thank you, sir. Thank you, sir. Bora sir is always there as a guiding light.
And of course, under the guidance of Servicer Bora.
Very because congratulations to all.
Okay. Tomorrow, Dipokda has to take the lead, and other examiner, I request all to come. And marking, Dipokda has assigned to some particular people. You all will be asking a question, but we have given specifically some, what do you call it? Assigned marking to particular people.
And how many cases will be there tomorrow? How many cases?
Yeah, sir. Tomorrow, actually, total we are having 17 paper as of now, because Yashin has given us a free paper. So one paper is gone. So 17 papers. So we have got 2 days. 2 days. That means 2 to 4 for tomorrow, and day after tomorrow 2 to 4. So 4 hours. We got 17. So tomorrow we will try to finish of 10 if it is possible.
Okay,
if the time does not permit, because at 4 o'clock we are having a inaugural ceremony, and guests from outside, our president and secretary from ESI will be joining. So we'll be sticking to that 4 p.m. So That's why we are keeping that option open. If we can finish 8 or 10, we'll do that. That's why we have not given a particular time to this PG paper. If we can finish more, then we'll finish 6 plus 2. That Dipokda, I think he will take note of it. Thank you once again.
Thank you.
Thank you.
Yeah. Please, you can leave this platform.
Thank you so much.
Gurabi thaki jab alap.
Moi asu.
Siddharth asana? Goal again. Siddharth goal.
Moi link to video ek minute ete.
Ena kaam koru tate join kori diu.
তাত জয়েন কৰি দিলে ভাল হ'ব নেকি? তাতে কথা পতা ভাল হ'ব।
এই বাকি কেটা ৰিমুভ কৰি দিয়া, বাকি যদি ই কৰিছে এটো লিংকত। Mintu.
Yes, sir.
Hey, remove kori dia na mage kita.
Can we stop this meeting?
Yeah.
We can stop this meeting and we will go to the.
We'll go to that directly. Time hoye goise to we have to again. Agote bohi jabo lagtate.
Anybody from this platform who is not understanding means how to go into the GBM?
Mohendra Soikia sir ase. Soikia sir apni join korile niki GBM?